The next speaker is John Marini, and he'll be talking to us about oscillations and noise, inherent instability of pressure support ventilation.
Thanks, Art. Bob has given you a superb talk on non-invasive ventilation and the intricacies of interfacing with its main mode, which is pressure support ventilation. What I've been asked to do in a relatively brief time is introduce you to something I'm quite sure you haven't considered, and that is that pressure support ventilation may not be as simple as we think it is. Bob's introduced this topic to some degree. I'm going to expand upon it and hopefully stimulate your thinking as much as some of our experimentation has stimulated ours. In any pressure-targeted therapy, you have an applied airway pressure, and you have alveolar pressure building and decaying during the course of the respiratory cycle. And pressure support is thought to be very simple because all we do is say how much pressure support should we put on. At least initially that's what we were doing before we had the adjustments to attack rate and expiratory flow cutoff. Pressure support is not all that simple, and it's not all that flexible. I think appearances are often deceiving. This is kind of a cute little optical illusion. It looks as if there's a curved surface and many curved lines in this picture, but it's more complex than that. If you look at the lines, they're all straight, vertical and horizontal. And there are many other optical illusions and things that we fool ourselves about that we should really examine more carefully. Characteristics of pressure support ventilation: you set an airway pressure target okay, but the breath depth and duration are variable, all breaths are triggered, and the transpulmonary pressure is patient altered. It is a flow cycled mode of mechanical ventilation, and that's great because that allows the patient to adjust their breathing cycle. But it implies that there's inherent inspiratory disequilibrium between the applied airway pressure and the alveolar pressure. The inspiratory duration is determined by patient mechanics and effort and the setting of the flow off switch, and Bob has introduced that already. The practical shortcomings of pressure support are that applied pressure does not auto-adjust to the need, so that if you start with a given pressure and the patient's requirements change, it's up to the patient to adapt. They can change because of impedance changes, secretions, bronchospasm, chest wall compliance, or auto-PEEP develops. If you have increased demand, it requires the patient to adjust muscular effort and or change their breath timing to elicit more machine power. So they can call for more frequent breaths from the machine or change the inspiratory time fraction of the machine, but not the pressure level that is being applied. The attack rate and the off-switch criteria do not, in general, self-adjust to the varying needs of the patient. And when you're comfortable and your attack rate is slow, and then you become agitated, you want a faster attack rate. And similarly, the off-switch criterion will often vary with the severity of the problem and the variations in the patient. These things do not change by themselves. You need to change them. Pressure support ventilation is disproportional to muscular effort, and this is a familiar slide to many of you comparing pressure support ventilation with proportional assist ventilation. And the point is that the muscular forces, 3 different muscular forces, are all met with the same airway pressure in pressure support ventilation. Proportional assist ventilation attempts to augment or decline the pressure in relation to the patient's efforts. And this is one very interesting approach, still hasn't been perfectly perfected for the clinical setting, I don't think, at this point. You'll hear much more about a neurally adjusted ventilatory assist from Christer Cinderby. I'm just going to simply say that you're getting much closer to the ventilatory control center with this type of regulator, where you are sensing the diaphragmatic activity from the neural traffic that is being detected in the esophagus. And when that's done, the adjustments to the ventilator output can be tracking along what the patient is really calling for in terms of their muscular efforts. Since Bob went through so much of this very well, I'm just going to point out to you what we're talking about when we talk about attack rate. You can have a very sharp attack rate or a very gentle attack rate, and you can have a flow cutoff value where the machine stops pressurizing at different percentages or absolute flows. Here, 50%, 25%, 10%. And this will become much more obvious why I'm emphasizing this as I go along. If your impedance changes, then the expiratory onset or the flow off switch will influence how much of the possible tidal volume associated with that pressure is going to be applied to the individual. For example, here you have a flow off switch, which is what you have is a flow tracing of the same duration with two different impedances. And the point being that you can very rapidly finish an inspiration breath during a restrictive lung disease, whereas with obstructive lung disease, you may have to go to a very long duration in order to satisfy the flow off switch criterion. I'm going to go by that and get to our point of interest, which is the patient with chronic obstructive pulmonary disease. It is here that pressure support ventilation is most helpful and also meets its greatest challenges. Because when we apply an airway pressure to the airway opening and have auto PEEP developed, then there is a driving pressure that is determined by the interaction of those two variables. If auto PEEP goes up and you have not changed the level of positive end expiratory pressure to offset it, for example, then the gradient between the airway pressure and the alveolar pressure is going to narrow as auto PEEP goes up. As auto PEEP goes down, the tidal volume is going to get greater. So there's an inherent possibility of tidal volume varying with the degree of auto PEEP. I think most of you know that. That sort of interaction determines why it is that there is increased sensitivity of airflow obstruction to the breathing pattern. And this is just from an old paper that we did with regard to pressure-controlled ventilation, showing that inspiratory duty cycle and frequency both have fairly powerful influences on minute ventilation as opposed to the restrictive situation, whereas varying inspiratory duty cycle does not much influence minute ventilation for a given frequency. In airflow obstruction, you need to have a fairly sharply defined inspiratory duty cycle to get the maximum minute ventilation from any given applied pressure. And when we talk about frequency, as frequency goes up in restrictive disease, minute ventilation tends to follow. In obstructive disease, because of the generation of auto PEEP, tidal volume declines as frequency increases, and minute ventilation comes to a plateau rather quickly. Now, Bob talked a lot about non-invasive ventilation, and pressure support has been our main mode of ventilation in that setting, and for good reason. But many patients do not tolerate non-invasive ventilation. Bob has spent a long time telling you about the tricks that we need to apply to get patients to tolerate non-invasive ventilation. There are many reasons. He went over these: claustrophobia, anxiety, mask interface leak, inadequate triggering or flow responsiveness of the ventilator, and mechanical interactions related to the pressure targeting, to the off switch and impedance, to ineffective leak compensation, and to the main topic that I wanted to address, could there be some inherent interaction in the setting of obstructive lung disease between pressure support ventilation and variability of tidal volume and inspiratory time? And what do I mean by that? I mean, for exactly the same patient triggering effort inherent in the mathematics that defines ventilation, there can be oscillation. And I'll show you examples of that just to whet your appetite. What first appears obvious often needs more careful inspection. This certainly looks like a South American dictator, at least to me. But when you look more carefully, what you see is it's composed of an old man, beautiful young woman, and a dog. This is another optical illusion, of course, but what I'm trying to say is that pressure support is not all that simple. Even if the patient is well adjusted, the pressure support level is exactly the same, you may get varying effects. And it's rooted in a branch of mathematics many of you know as chaos mathematics. I know very, very little about this. This work is really the work of John Hotchkiss, Philip Crook, my mathematics and physics-oriented colleagues. But surrounding us in the atmosphere, in water, in flowing water, when you took a shower this morning, are dynamic events that are very difficult to predict in terms of what one particle of water is going to do at a given time, because it's sensitive to the initial conditions. And I'll say more about that in just a second. So whether we're talking about a flowing water or we're talking about the atmosphere, talking about the weather, this being Katrina, this looks rather organized, but it is a chaotic environment with what's called a strange attractor. You can think of it that way. And this goes back, fittingly enough, to Lorentz, who in the early 1960s set his computer to working in a weather modeling situation and expected to get a stabilized result and to get an answer. He walked away from his computer, and when he came back, he found a totally different answer than what he found the first time. And he traced back what was happening, and it turned out that his computer program was very sensitive to the initial conditions. So it went from a very predictable behavior to a very unpredictable behavior due to small input errors that were amplified over time. What has that got to do with pressure support? You can transition in certain circumstances when the mechanics and the interaction with the machine are set up in the right or the wrong way, to transition from stable behavior to unstable behavior, from stable behavior to periodic behavior, and then eventually into chaotic behavior. And let me show you some reasons for that. When you look at the pressure on inspiration applied to the respiratory system, and you're talking about a passive respiratory system, the pressure that you need, it relates to the resistance, to the tidal volume, and to the end expiratory pressure. Now, the end expiratory pressure is a recursive function in pressure support ventilation. And before you go to sleep, what that means is that the end expiratory pressure of a given breath is a function of the end expiratory pressure of the preceding breath. So there is the potential here for sensitivity to initial conditions, the chaos type of mathematics. And mathematically, these equations can become extremely complex, even if you're dealing with linear resistances, unchanging resistances, and especially if you're dealing with complex and dynamically defined parameters. The key variables determining pressure support ventilation instability during mask ventilation are mask leak, flow cutoff percentage, and the factors that amplify auto-PEEP, respiratory time constants, and ventilation requirement. And I'll just give you some examples here. If we look at mask resistance along the horizontal axis in a mathematical model, when you have a tight mask, you have stability. Your inspiratory time for an unchanging effort is going to be identical. Your tidal volume is going to be nearly identical for the same effort, and there's no problem. When you get a leak, not only do you have to compensate for the leak, but guess what? The ventilator is going to have a hard time to do so. By the model, when the mask resistance falls so that there's a substantial leak, then you get chaotic behavior in terms of inspiratory time. Periodic and then chaotic behavior. These are just further examples of the interesting patterns that can develop in a mathematical model between mask resistance and inspiratory time under leak conditions. This is a mechanical inspiratory times in a fixed frequency model of pressure support ventilation where the frequency is unchanging. And you can see as the mask leak resistance falls, then you begin to get different cycles giving you much different inspiratory length times and consequent tidal volumes and sense of discomfort. If you fix the inspiratory time and allow frequency to vary, you also get some interesting patterns in theory. Small variations in the flow cutoff as well, not only mask leak, may influence the stability of pressure support ventilation. The flow cutoff of 50%, 46%, 44%, 43.5% result in greatly different inspiratory times. This is inspiratory time on the vertical axis, and this is the number of cycles on the horizontal axis. You can see that a small change in what you select as your flow cutoff signal may be important. Let me go through that. You can see aperiodic behavior, just like we were talking about before, in nonlinear models as well as simplified linear models. What about invasive leak-free pressure support ventilation where you've intubated the patient? The same factors apply except for leak. It's the flow cutoff, the factors amplifying auto-PEEP, the frequency with which the cycling occurs, and how good your flow sensor is. Any small deviation in your flow sensor in the right situation can also induce chaotic behavior. Examples: expiratory off-switch and tidal volume in airflow obstruction by theory, flow cutoff versus tidal volume. This is in a mechanical model in the laboratory. It's not just theory. This is a model that is being methodically giving the same effort and looking for the responsiveness to pressure support ventilation. And as the flow cutoff is varied from 0.45 to 0.3, you get now oscillating behavior in terms of tidal volume. And it's quite interesting to watch this in the laboratory as it develops. This has nothing to do with effort. This is in a mechanical model. This is cycle-to-cycle oscillation in a mechanical model of pressure support with respect to the auto-PEEP value. And the sensor noise in a linear model of pressure support ventilation near the point of instability is also very important as well. Okay. Does it ever happen in humans? We actually have data in humans that such instability does occur in non-invasive ventilation. This is ventilator cycle time and cycle number, and you can see the cycle time length varying in varying conditions of interactions between obstructive disease and pressure support. If you believe me, and I don't think you should because this is all theoretical and experimental, if you believe me that there is some inherent instability in pressure support ventilation in the setting of obstructive lung disease, your feeling should be, so what, okay? Well, it may have something to do with comfort and synchrony that people feel, especially in the setting of obstructive lung disease. It certainly can account for missed triggered cycles if autopeep varies all over the map. And there is some interesting information from Martin Tobin's group and others that sleep quality may be influenced by pressure support ventilation in patients with obstructive lung disease. Comparing assist control ventilation with pressure support, the number of arousal episodes and apneas are amplified by pressure supported ventilation. You may think this talk has been out of place in a lecture like this. I just think that we cannot assume we know everything about the familiar. This is something that I think really complicates the design of machinery. And until we get into a place where we fully understand the underlying physiology and the interactions, then we will be still searching for the ideal mode. Thank you for your patience.
Thanks very much, John. That's a lot of new data that I hadn't seen. Very, very, very interesting. Open for discussion. A couple in the front here. I should mention that both, all of the information that I've presented, or the majority of it, appeared in the Blue Journal in 2 different papers. First author, John Hotchkiss, and in the last 2 years.
Beautiful talk, John. Is this chaotic input to the respiratory system, how does the ventilatory controller modulate that? Does our control system stabilize that chaos or amplify it?
I suspect there are interactions there that need to be explored, Rolf. I have no direct answer to you, except that our controller integrates usually over a couple of cycles, couple or 3 cycles. If we have bouncing auto-peep values and inspiratory length cycles and supports, I don't know how the controller could possibly keep up with that. Christian?
Hello? Yep. It's a fascinating topic, and as I'm having the same question, it's like, I mean, with all the reflexes involved, the emotional changes of a patient, pain, anything that would inflict, I mean, because I've been always fascinated about this thing about we love to see square waves, round waves, nice systematic things, nice kind of screen on the monitor that goes up and down in a nice rhythm. We think this patient is doing great. And in general, I mean, if you think a car you put on the cruise control and you go through a city and you go on a highway on the same speed, I mean, this is really what you're talking about, I think. Mm-hmm. That you really have the point that you leave to the patient to do all the adjustments because you're not going to change anything.
Right.
And I think this is really like, it's a beautiful presentation, I must say. Thank you.
Thank you.
John, what was pretty striking was the sensitivity to the flow cutoff. We're at, I don't know, 45% perfect, and 44.5, it sort of becomes chaotic.
Yeah.
That's sort of, it's intuitively, it's hard to understand. Could you sort of try to give us a better feel for this? And do you think that happens clinically as well? Can we use that information and think about, geez, you just change things a little bit, you can have an incredible impact on the clinical outcome?
Well, I didn't really have time to get into the details, and I'm not sure I'm fully equipped to do so. But let me give you and the audience a little bit better feeling for why this thing is occurring. If I've developed auto-peep, my next breath from the pressure support will be very small. The tidal volume will be small, and the next auto-peep will be considerably lower than it was before. I apply the pressure again, and suddenly tidal volume goes way up. Now, certainly the chaotic behavior does not occur in patients with normal physiology. And you have to have the situation almost perfectly set up for chaotic and periodic behavior to occur for that to work. And patients with airflow obstruction, if you put in logical parameters for such patients, are susceptible to this kind of periodic ventilatory support. And the transitions are very abrupt. just as they were with in Lorentz's models and other models that have been done. You reach a certain point, and then you start breaking off into splits, and then further splits, and then at one point becoming chaotic, and it's over a very narrow range of numbers of cycles. So I can't give you the kind of detailed answer that's appropriate, Art, but it does have a great deal to do with the mechanics of the patient and the flow cutoff setting and the things that I discussed.
It's interesting. You said it has to be perfectly set up, which is, if you think about it, one of the places that chaos theory has been sort of looked at is in trying to predict the weather. Why you can't predict the weather, and think about the perfect storm, sort of the same sort of thing. There is a great book on chaos called Chaos, and I forget the author. Do you remember the author? The first half is actually quite understandable. Glick, G-L-I-E-C-K, I think. Yeah. It's actually quite good. It's for the lay public, if you like. And as I said, most of it is pretty comprehensible. And you may want to pull that out, read that. I think it's very good if you're interested in this excellent presentation. Any comments, questions from the audience? There's one over here.
Yes, John, in the spirit of turning a bug into a feature, how does the magnitude of these chaotic effects compare with normal biologically variable ventilation parameters?
I think when an individual is not stressed, then there is quite a lot of biological variation. This is not really adaptive in any way that we can understand. I think it's a pathophysiological phenomenon rather than a physiological adaptation. But it's a natural question to ask. Biologically variable ventilation occurs, usually in patients who are well compensated. When I say you have to be perfectly set up for this, I don't really mean that. I mean the mechanics have to be airflow obstruction, and you have to have interactions between pressure support and autopeep in order for this chaos to evolve. And I don't think it has anything to do with biological variability. And does it have any benefit for the subject? It's arguable in the setting of acute respiratory failure due to ARDS, where it might be helpful in keeping the lung well recruited. In a setting where the lung is already overinflated, I don't think it has much value.
And from your slides, it looked like the effect on like FRC and tidal volume were like orders of magnitude larger than normal biologically variable.
Exactly.
Is that correct?
Yeah, for sure.
Final comment, Rolf. Microphone up here.
Is there any relationship of this phenomenon to the lessons of early versions of PAF, where the breath-to-breath variability in elastance and resistance on account of using different muscles, etc., set up an unstable system? Can I think about this the same way?
Not the same way, but it's another unexpected, it actually relates to your first comment, I think, that the controller will respond to proportional assist in such a way that you get oscillations that are more physiological in nature, I think, and more predictable. This kind of behavior is emerging purely from the mathematics of the interaction.
Great. John, thank you very much for your chaotic talk.